We embarked doing MCG Consulting services because there are a lot of questions around our organization about how is the team performing. So are we putting too many cases into observation? Or are we putting too many cases into inpatient? Things like that. Really, the concern was we're putting too much into the observation. And so as many times as myself and my team audited, there wasn't a whole lot of confidence within the organization. So that's where we connected with MCG to say, do you provide these services? Love to have you come in, quarterly audit our team to make sure that we are utilizing the tools that you guys have provided us effectively and making sure that we're putting the patients in the appropriate level of care. And so we embarked on that with Cindy. Last conference, last MCG conference was when we were working to kick it off with the contract and everything. And what's been great about it is we're able to be flexible on what is audited. And so, just by the change of dynamics within the organization, if there's concerns for the inpatient, we'll have her focus on inpatient. If there's concerns for OBS, we'll have her focus on OBS. And most recently, we were having her focus on short stay inpatient cases because we have a payer that just keeps denying us on these cases and we don't agree with that. And so we want to make sure that we're appropriate on our end. So what we found with MCG doing the consultant services, though, is I can then take that information back to the payer and say, listen, here's another case that was audited by us. That's an example of a case that you just denied. MCG is the same tool that you use, and they're saying that this is what we should be doing. So we have had a couple of conversations like that with the payers. It's been fantastic. Everybody in MCG in general is real easy and very responsive to work with. And Cindy has been fantastic in making sure that we're getting what we need and we're getting in the way that we need it so we can communicate it back to our leadership who don't necessarily know utilization review or what we do, right? And some of the information she has given back has been so helpful to the leadership team in the sense that we can see the guidelines that the teams are selecting, making sure that they're picking the appropriate one for the case that they're reviewing. If they're not, then how can we fix that? She's tracking and trending for us cases that maybe inpatient was appropriate and the UR nurses had reached out to the physician to sign off on that inpatient order, but we didn't get it signed off on. Or she'll point out cases for us that we are telling the physician this should be downgraded to OBS and ED, but the physician leaves it as inpatient. And that's really helpful for me as well as to take back to the leadership team saying these are cases that MCG, the software tool that we are using and partnering with, are saying my team's doing the right thing, but we can't get our physicians on board with it. And my director and manager will take a lot of the information that Cindy feeds back to us in the PowerPoint slides, and she'll share it directly with the team. She will share their performance and how they're performing, and she'll pull out case studies for their monthly meetings, and they really enjoy it. They want to make sure that they're performing at the best that they can perform too. What I get back, we get back actually a few things, but from my end of what I get back, I get about 25 PowerPoint slides that will go through high level the cases that were audited, how many cases we couldn't audit, MCG, couldn't audit, how many cases were audited but didn't end up having a UR review or a physician advisor, what cases the physician advisor went into, what cases were appropriate for inpatient, what cases were appropriate for OBS, cases that a payer denied, and if MCG agreed with the payer or agreed with Kaleida on that case as well. It is a lot of information that comes through. It will also give us our guidelines, what guidelines the team used, what guidelines we might need more education on to give the team education on. And then we've gotten Cindy to kind of summarize that into an Excel for us. Well, she'll put all our patient account numbers in, and we'll just mark X's if meet MCG guidelines, didn't meet MCG guidelines, appropriate level of care and not appropriate level of care, so I can pivot and filter that out real nicely quickly. We're going to continue with you guys for as long as we possibly can. It's important to me to always have somebody external coming in to look at the work, because as much as we think that we're experts in our area and what we do, you guys are experts in everything, and you're seeing multiple different facets of all healthcare organizations, and we can only grasp more of that learning opportunity from you. It also gives not only our leadership team confidence in what the team does, but it gives our compliance team confidence in what our team is doing. We have a pretty robust compliance team, And any audit you guys perform on the team, I actually have to share it with the compliance team. So yeah. So this will be continued. I do it for my coding staff and my clinical documentation team too. Always external audits. Was really a point where I was reaching out to numerous resources trying to find somebody if they actually did audit on level of care medical necessity. And what I found were people who were willing to put it together and, pay a lot of money, but they're not necessarily what I would consider the experts in that area. So when I finally reached out to MCG and had worked with Karen and Kelly and Julie with it, and to hear that you guys were working on that was like a godsend. To have, to your point, the clinicians come in and audit other clinicians to make sure the teams perform. And I'm not even meaning when I say team, the UR nurses. I'm also meaning my manager and my directors and my physician advisors to make sure that they're performing appropriately.